is the one which we normally use for our transformal approach. So this is the Cambridge triangle. It's a three-dimensional right triangle. But whenever we go into this triangle, we are using the fluoroscope. So that's why it becomes a two-dimensional for us. So what all we can see, we have to assume that there is an exiting root over there. But what we can see is the base of this triangle, and this is the height of this triangle, which is formed by this facet over here, and the base of the triangle, which is formed by the superior border of the inferior vertebra. So the third side is formed by the exiting root. So this is what we have to assume, because we cannot see this in the fluoroscope. The area of the Cambridge triangle, as we see that it is minimal at the L1 and 2 level, and it goes on increasing, and it is maximum at the L5S1 level, the Cambridge triangle area. But despite having this big area in the L5S1 level, whenever we have pathologies in the L5S1 level, this becomes most compromised. The Cambridge triangle is most compromised in the L5S1 region. Probable reason for this is that because of this angulation of these facetal joints over there, that and the increased area of the facetal joints over here, that may cause reduction in the size of this Cambridge triangle. So you can see from here, there's an operative, there's non-operative, and you can see at L5S1, this has become very narrow. It has become like 80% reduction in the size of this Cambridge triangle in the pathological disc. So what is important here is to understand is whenever you have pathologies in the L5S1 region, we should be very, very careful about entering into through the Cambridge triangle, because we may get a very tight foramen or the Cambridge triangle over there, and there are good chances of injuring the nerve roots over there in case of L5S1. So better to go for the interlaminar approach. The actual working.
I just want to make a quick comment about the Cambridge triangle. The Cambridge triangle, actually, like Dr. Suranga mentioned, it is three-dimensional thing, and we are entering it through the two-dimensional space with the X-rays. What is important to understand is as it grows laterally, it actually becomes shorter and thinner. So if you are doing a far lateral approach, the triangle is actually decreased even more. So just bear that in mind.
So this is actually working zone, or we also call it it's called a discal space. This is actually working zone. Basically, we are not considering this this part of the nerve root, which is forming one of the angle. So we are not considering this part. We are just taking this part as this is a actual working zone, which we get. You may see that there's this is a dura over there. This is forming the middle border. This is a lateral border, which is formed by the exiting root over there. And the distance between the dura and the exiting root, whatever we get here, is this is the superior border, and the inferior border is formed by the same what we are getting with the Cambridge triangle. So this is actual working zone. Now, if you look at over here, this actual working zone is again basically you can see here starting from L1 L2, it start increasing in size. It goes up to 116 at L4 L5, but this again reduces over here. The reason behind reduction of the space of L5S1 is mainly because I'll show you on the coronal sections also, because the nerve root, the S1 root, which starts above the discal space, L5S1. So it is not a dural lining which is there. Now we have the S1 root which goes like this. So S1 root is already exiting the dural sac above the disc, L5S1 disc. And basically it starts going towards the laterally, and that reduces this working zone. Okay, so on all other spaces, we have this dura as one of the lining over here, but at L5S1, we have this S1 root which comes out over here, and that reduces the actual working zone. So that is why we have this narrow, as compared to other, we can see here, we have this L5S1 reduction in the actual working zone. all these surfaces you can see here. There's a maximum at the L4 L5 level. So this is the best to start if whenever you are starting your endoscopic hysterectomy procedure. This is the best level you should start at L4 L5 level. This is, you can say that it is one of the safest disc to start with. This we can see on the actual working zone. We can see it on the coronal sections. You can see that's an exiting route over here. That is exiting route over here. This is the circular part over here between the exiting route and the dura over here. This is the lower part of this Cameron's triangle over here. This is Cameron's triangle over here, and this is the route over here. So this is what I was telling you, that you can see here at the L5 S1 level, the exiting route is already S1 is already coming out of the disc. I show you in other MRIs also. The DRG, we know that it lies into the foramen. So whenever we are working inside the foramen through the transforaminal approach, there are good chances you may get your DRG may get compressed for some time, and the patient may have some paraparesis or some paresthesia post surgery. So this is quite common after these transforaminal surgeries. But if you know your pathology very well, if you know your trajectory very well, in that cases you can avoid all these compression for the longer time. DRG, except for the S1, yes, this is important. DRG of the S1, it lies somewhere over here. It is not into the foramen because, as we know that this is what I was telling. If you look at this, all of the nerve roots, they are coming out of this dural sac almost at the level of the pedicle, whereas the S1 root, which exiting out of the dural sac, and it forms the DRG over here before entering into the foramen. So S1 is the exceptional to this, that it doesn't lie into the foramen. The coronal sections will help you in whenever we go for the interlaminar approach or the biportal approach. At that time, it is good to see these coronal images, because when we are going inside, we are almost blind. We are going to under fluoroscopy guidance. We must know where to put our working channel, where to put our guide wire, where to put our dilators. By looking at these coronal sections, we can see that where this herniation is pushing the nerve upwards, downwards, medially, laterally, where it is pushing, and we can safely go with the interlaminar approach. So it is good to see this coronal images also. So this is what I was telling. In the lumbar spine, the nerve roots, they exit the thecal sac approximately the same level of their respective foramen. So as we know that when they come out of the thecal sac like this, you can see here, when they just come out of the thecal sac, they go into this groove in the middle part of the pedicle, middle part of the pedicle, and then they start going towards the foramen, and then exit like this. Except for the S1, which is like, now you can see here, this is already gone out of this over here, and then it is going into the pedicle over here. These are some of the parameters which we should know, just to see that where the nerve root lies, what is the relation of the nerve root with the disc, with the pedicle. So we should know about all these things. So pedicle to the nerve distance, which is like this, which we normally use for the transforaminal neuroplasties, that is from 2.9 mm to 6.2 mm. As we go down, the distance will increase, because in the upper part of the lumbar region, the exiting roots are taking more of the horizontal route. So the space between the pedicle and the nerve root is less as compared to the lower region. As we go down, they start taking the more vertical angulation, and that is why we have a increased space between the L5 between the pedicle and the nerve roots. Pedicle to dura distance. Pedicle to dura, this distance is around 0.9 to 2.1 mm. This distance is like this over here, from the pedicle to the dura. So this is what one of the landmark when we do endoscopically, when we do go inside the foramen, when we just cross the SAP, we go down and we enter the disc over there. So this is what is our one of the landmark that we want to keep our needle entry into the disc space at the middle particular line. Because if we are not inside the disc and with the needle, we may go inside and we may touch the dura over there. GRGs, as I mentioned, that they are very sensitive to the pressure. Uh, so whenever we are doing some endoscopic procedure, there are chances that your DRG or the exiting route, they may get compressed and they may cause neuropathic pain for some time or maybe some paraparesis for some time, which is common. But you don't have to worry about that. You just have to be very quick on this thing. Don't manipulate too much over here. Uh, Especially the cranial tilt of your working channel, we should avoid that because that will compress your root for the longer time. Disc root distance at the middle border of the pedicle, disc root. This means this is a disc and a root distance. You can see here. This is maximum at L1, L2 level. And because we know that this taking the more of the horizontal approach, this exiting route. So that's why this distance is more. This distance is more. As we go down towards the L4, L5, S5 level, we have this distance which is less. So the chances of the DRG compressions are less if you're doing something in the L1, L2, L2, L3 level, because we have a good distance between the disc and the root over here. At the mid pedicular line, that means over here, mid pedicular line, this distance is 0.4 to 3.2, 3.8 mm. Again, it is maximum at L1, L2 level and minimum at L5, S1 level. Intersection, where it is happening, intersection of the nerve root, it usually happens at the lateral border of the foramen. That means on fluoroscope, what we can see is the lateral border of the pedicle, lateral border pedicle. This is what we should avoid. We should avoid whenever you're going inside the foramen using this Camden's triangle. That is why it is important to keep checking AP and lateral till the time you reach into the Camden's triangle, you reach inside the disc. Because if you are in the lateral view, if you are entering the disc and you are still in the lateral part of the foramen, that means the lateral pedicular line, there are good chances you may hit the nerve root. If you enter from the disc from here, this point, you may damage when you are putting your sleeve inside. You may damage the exiting root. So that is not a good idea to enter the disc from here. In the initial days, this happens. A lot of time we have seen people tend to avoid going more medially, but we must remember that if we keep it laterally also, that is also dangerous. So L1, L2, L3, they are closer to the lateral border of the foramen, so there is less chances or the risk of the injury if you're doing something in the upper lumbar level. At L4, L5 takes more vertical course, so occupies the foramen's disc space. So that's why the chances of the DRG involvement or the compression of the nerve roots, exiting roots are more if you're doing something in the L4, L5 level. Chances of the nerve injury, they are maximum at the L5, S1 because as we just mentioned that one is that L5 is taking a more vertical approach. It is more closer towards to the disc. That is one reason. L5 and S1 is also coming out of the dural sac and it is also taking the lateral approach over here. So that is why we have a less working space at the L5 S1 level, and over and above, if you have a disc degeneration, there is a thinning of the disc. In those cases, there are good chances that you may damage the nerve. So there's a maximum chances are there if you're doing something transformational at L5 S1. So you have to be very, very careful if you're doing something at the L5 S1 transformational approach. So what is your approach for L5 S1, sir?
So for L5S1, I basically look at where the herniation is. If it's a central herniation, I do an interlaminar approach. If it is not, then I do the transforaminal approach. With the transforaminal approach, you have also to consider that the iliac crest, you have to always evaluate it preoperatively, and also I evaluate it, during the surgery. But basically, if your crest is midpoint of L5, you have to take a very steep angle. So it's a little more challenging to do. So for L5S1, you have to be careful. You have to evaluate the person very thoroughly before you put the patient into the operating room.
Yeah. So usually I just do it for the foraminal herniation which are extending up to the foramen. Usually I do it with the transforaminal approach for alpha S1. Like
Right.
if it is very high, if it is going up to the L4, L5 disc level, that level I usually avoid doing transforaminal approach for the alpha S1. So there are some nomenclature we must understand this nomenclature because this will help you in understanding the pathologies also, and this will also help you in understanding the what kind of herniation, which approach you should take. These are the fissures. We know that this is a concentric fissures, the radial fissures, and these are transfer fissures. Disc bulging, when we say bulge, it is a diffuse or the complete diffuse bulge over here, or the asymmetrical bulging disc over here. That is uh, where we have this annulus is totally bulging outside. So the annulus is entirely intact, but it's just a diffuse bulge of the disc. Entire disc is bulging. So obviously, these kind of bulges are not good cases for your endoscopic procedures. Maybe we can go for some percutaneous decompression procedures where we can go inside and we can remove some material from inside, or we can do something inside the disc to shrink the disc inside from inside. Uh, these are not the good cases for the endoscopic procedures. If you have a protrusion, this protrusion is there. If you have a ligament of your annulus is intact over here. Again, there is a you can avoid going the if you have a herniation like this, we should avoid going to the outside in technique where we go into the canal and we start decompressing from here, because the annulus is intact. We want to preserve this annulus in these cases. It is better to go inside and we can decompress it from here in such cases. If you have an extrusion like this extrusion, these are the good cases where we can go and directly target a fragment that is outside in techniques. So how we did, decide that on the MRI that whether it's a protrusion or the extrusion. This is uh, a simple formula we can see here. When we see that the base is bigger than the height, then it is called a protrusion, and when the base is smaller than the height of this herniation, then we call it extrusion. Because the moment it comes out, this is also very logical over here, because these kind of extrusions are difficult to remove from inside. But if you have this kind of protrusions where the disc material is coming out, it is easy to extract this nucleus material from inside out technique. Whereas if we have this kind of where the annulus has retracted, the annulus has a good capacity to retract. So whenever the disc material comes out, it bursts out, the annulus will retract, and then it becomes difficult to extract this material from inside. So in those cases, we should go and target this fragment over here. All these things I'm just covering it, but we'll be discussing in detail when we discuss about other approaches. Sequestration, when we say the sequestration, because whenever the nucleus material is not in continuity with the parent disk and it is lying somewhere else, it may go migrate downwards, upwards, or maybe posterior also. At times it will go posterior also. In that case, we can select our where the fragment lies, and accordingly we can select our approach. This is the nomenclature we all know about: the central herniation, the paracentral or the subarticular zone, which is just below the articular process over here. This is called as paracentral herniation. Then the foraminal herniation and the extraforaminal herniation. All these things we can see on MRI. The axial sections are good for this. We must know how to read these axial sections. So axial sections are basically taken, like if you see here, the axial section is taken uh, from above the foramen level. Because why we are saying that is above the foramen level? Because you can see this pedicle over here on both the sides. You can see the vertebral body over here. We can see the dural sac over here, and just beneath this pedicle, you can see the exiting root, which has come out of this dural sac and is lying just medial to the pedicular groove. There's a groove over here, which is the pedicular groove. So this exiting root lies over here. And this is lamina over here. This is a epidural space. There's a ligament of phlegm over here. And as we go down, now we can see this. As we go down, now this section, we can see that this section is taken from the just the upper part of the foramen over here. Why we are saying this? Because we can still see some particular part, and we can see this exiting root over here. That is going towards the exiting root is going towards the foramen. As we go more down, now we can see here, this section is taken from somewhere from the upper part of the foramen from here. This axial section is taken from somewhere from here. Because now we cannot see this pedicle over here, and on both the sides we can see the nerve root, which is lying over here. So nerve root, as we know, that lies just below the pedicle over here and into the foramen. So this is the exiting root which is into the foramen now. You can see here. And there's a dural sac which is containing all the traversing roots. You can see this exiting root is going out over there. And as we approach towards the disc, now you can see here, as we approach toward the disc, as we approach over here, when we reach the disc, we can start seeing this nucleus pulposus and nucleus fibrosus, and the exiting root has already gone out and it lying somewhere over here. You can see that is the exiting root. And there's a traversing root which is still within the dural sac and is going laterally now towards the periphery of the foramen, towards the foramen. So you can see all these, whether if the migration is there, if it is an upward migration, you may see some herniation over here. If it is downward migration, you can see some herniation over here. So all these sections are really very important to see, to examine before we take the patient, because this will guide your the scope also and your trajectory also. So this is somewhere which is we are taken from the mid front center of the intervertebral disc, and you can see this nucleus pulposus, annulus, the exiting root, the traversing roots, the dural sac. You can see the facet joints over here now. And this is where we basically intend to go between the exiting root and the traversing root. This is the area what we select to go inside the disc or inside the canal, depending on the type of the herniation. Angulation and the distance of the entry point, again, as I mentioned, that it all depends on the type of the herniation. Whether we want to go for the transferal approach or interlaminar approach, we must select our identify the disc pathologies where it is lying, and then accordingly we can select. These are just a rough guidance. If you have a central herniation, diffuse bulge, we want to decompress. What we also call as core decompression. If you want just want to go and decompress the disc from the center, in that case we can go like this in this along the subarachnoid facet, and we can go inside and we can decompress the disc from here. If you are having this foraminal herniation or foraminal herniation, then we have to go take this as a guide, and we can reduce the distance from the midline. So we can just follow this line. We can just follow this line over the skin over here, and we can identify the distance from the midline, this midline, and from where it is coming out of this over the skin. For that, we have to have a full complete axial image. And we can identify that, yes, this is the point. This is just a rough guidance. Don't just take this as a thumb rule. It's just a rough guidance where we can identify that if we have to go for the posterior annulus, in that case, you can see here for the posterior annulus, we have to go little lateral, more lateral. And we can identify, we can see here, we are going towards this. And this is also giving us a one confidence that yes, this is a trajectory. If I take this trajectory, I'll be avoiding this retroperitoneal space, and I will be avoiding, I can be targeting our my fragment. This is when we target the foramen, directly into the foramen or inside the canal, when we have a big extrusion over there, when we don't have to go inside a disc. We just have to enter into the foramen and start going to the looking at the foramen, clearing the foramen, and identifying the extruded material over there. In that case, we have to go far lateral approach. We have to take a far lateral approach. There are different techniques. One is this, where we can identify the angulation. Angulation is difficult to see that because we must remember that all these MRIs are taken in the supine position, and when the patient is inside the OT on the table, they are prone. So that also changes make some variation in the muscle mass and the trajectory. this is the angulation what we can see on MRI also. We can identify what angulation we can go for what level of the disc. And uh, some people they do, most of the people, we have seen that most of the people, they just go AP and they start taking the angulation from the lateral. Uh, we can use the angulation of the fluoroscope. We can parallelize the end plates. That is another method. Normally, I do that only because whatever we are seeing on the MRI are basically based on these angulations. They have already taken this parallelization into consideration. So, if suppose something is here at the alpha S1 level, they have taken these sections like this. They have not taken the section like this. They have just taken all these sections like this. So whatever we are reflected in the axial images, they are based on this angulation. So so when we go inside, when if you have to go for the alpha S1, if we parallelize the end plates, that will give us the exact clue where is the fragment lying. Because whatever you see on the MRI is based on this angulation. So this is what normally I do. I go for the parallelization and then I go inside. Sir, what is your choice, sir? You do parallelization or?
So for me, actually, I do the, I do it on the operative time. I basically do the transverse view and the inclination view, and then I decide.
Okay.
But standard to get an idea for people, on the lateral view, you need to be like 12 to 13 cm. And then you have to angle it depending on where you are. The only place where you have to angle it real steep is at L5S1. And the angle of the needle is around 25 to 30 degrees to get in.
Yeah. So that also everything depends on the patient. Habitus also, patient is very obese, then that will also change the entry point also. And which we are going to discuss in the lectures of that the type of the herniation, what angulation we can take, and what distance from the midline we can take. We can to reach if it is a foramen herniation, if it is a paracentral herniation, if it is central herniation. So the angulation will change, the distance will change depending on the type of the herniation also. Uh, because most of the pain physicians, they are comfortable in the parallelization and then going and targeting their foramen and the disc. Uh, uh, so maybe you can uh, when we discuss when we do this category workshop, that time we can see what is convenient to you, what is comfortable to you. You can choose that. But normally I do it because since we have the pathologies which are detected on MRI based on the angulation what they have taken. So that is why I choose usually paralysis and patient and go inside. For the far lateral approach, if you're targeting the canal, whenever there's a sequestrated material which is lying to the canal in the or the central herniations, where we have to go inside into the canal. In those cases, there is another method which is called the far lateral approach. We can use this as a guide for the far lateral approach. We can just go lateral and we can, after paralyzing, we can just go lateral and we can see the tip of the spinous process, and we can select our entry point over the skin over there. So there's another method for the far lateral approach. Uh, some people, they also do like whenever they go for the interbody fusion, they also use this much lateral position. But for us, for the transformal endoscopic decompression, I think you should avoid going below this tip of the spinous process, especially at the L3, L4 level and above. We should not go at this level. We should not cross this tip of the spinous process. So decision making, what type of the herniation, depending on the patient's anatomy, patient's size of the patient, the type of the herniation, uh, the sequestration or the migration, whether it is upward migration, downward migration, all these things will depend. We can see on the MRIs, and accordingly we can set our trajectory. But before that, we must know all these anatomy in detail. We must know how to read the MRI. Don't be just dependent on the MRI reports, what is available with you. Don't be dependent on that. Read it properly, see your transition, whatever the transition was before taking the patient inside the OT. You must study your MRI, patient's MRI very well. If you have any doubt about the stenosis, in those cases, you should not be hesitant in going for the CT scan also. So with that, I'll finish here. This is all about the basics of the MRI and the clinical anatomy, which is relevant for the endoscopic procedures. If you, sir, you want to add something, sir?
No, I think this was an excellent lecture, very detailed, lot of information.
So we'll be covering this anatomy when we discuss about the different approaches. That time also we'll cover the anatomy part. The pathology,
Yes.
this is just a basic idea how to see this pathologies and how to what are the clinical anatomy which is relevant for us. In the subsequent lectures, we'll be covering everything in detail again.
So there's a question, Doctor. I don't know if you're seeing it or not, but Dr. Arifin is asking whether he can get the recording.
This recording of the class, yes, we will be uploading it on the portal. We'll upload on the portal. This will not be sharing on the WhatsApp or the other places, but you can watch this again on the portal itself.
Thank you, sir. Thank you.
Sir, one question, sir.
Yes.
Regarding the spinous process and level of this one entry, could you just clear this a bit, sir? You in the second last slide, you were talking about the tip of the spinous process and the yes, sir. So regarding this, can you just?
So this is for the cases where we have an extrusion over there, and we don't want to go inside the disc. We want to target the canal directly through the foramen. In that cases, we go like this far lateral approach, right?
Okay, yes, sir.
So if you have to go far lateral, if you have to enter into the canal and we want to target the fragment from there, in that case we have to select this far lateral approach. So why I'm saying this, because if you choose this as a far lateral approach, with this there are good chances that you will avoid this retroperitoneal space. Otherwise, what is the guidance? The guidance is not there, because all depends on the patient habitus also. If the patient is very obese, see 10, 12 centimeter, 15, 12 centimeter, 14 centimeter, if you say this is the normal dictum is that for L5 S1 go at 14 centimeter, L4 L5 go 12 centimeter, L3 L4 go 10 centimeter. That is just very rough, very superficial way of calculating. Suppose the patient is just very thin, just patient is for 50 kg, right? For that person, L4 L5 12 centimeter is like esteem lateral.
Yeah.
You know. So what is the guidance? So for that, what we can do is we can see this as a lateral image. You identify the spinous process, the tip of the spinous process, and you take this over the laterally, and this is your entry point now. So this becomes a far lateral approach, and you can go directly into the canal.
So I just want to clarify one thing quickly.
Yes, sir.
The other aspect of making it safe is to look at the posterior facet line. So on the lateral view, you can always see the facets.
This one.
Right. So if you project that on the lateral view, you should not be at the posterior facet line. That's the safety margin. Because if you go beyond the posterior facet line, you can go into the retroperitoneum, basically.
Yes.
So the posterior facet line is here.
Yeah.
If you come in lower than that, you're going to get into the kidneys and the retroperitoneum.
Yeah. So this point, Dr. Datta is telling you about this point. This is the point, right? This is the entry point.
Right.
You should never go beyond this point. But usually for the canals also, you can select this one or this one, maybe midpoint of the spinous process and the facet joint. Midpoint of that also you can go safely. But the margin of safety is very less. If you are using this, if you're taking this as a as a guide for the lateral approach, the margin of safety is very less. Because even the minor steep angulation, you may enter into the peritoneum, interperitoneal space. Guys, any other question? The more you will ask, the more you'll get benefited with this. So, okay, there's no question. All right. I thought there would be a lot of questions. Maximum questions are there in the basics only. Okay, all right, sir.
Sure.
I think there are no questions. Maybe then when they start reading, they'll have some questions.
Sir, any books that you would suggest for us, the beginners, to start with, sir, for this?
There are so many books available. Dr. Datta is going to share some of the articles, which are the good articles. I think start reading.
I would recommend. One which is more atlas based. So one of the books that I started out with is the book by Dr. Ganchoy. I can show you a cover of that. I'm trying to just give me a few minutes. I'll try to see if I can project the cover.
Yes.
And sir, do you have a soft copy of this, sir? PDF copy of this?
I knew Shri is going to ask this.
This is a copy of the book. Let's see if I can get it.
Yes. Okay, endoscopic spine.
Yes.
It's a very nice book.
Yeah.
It's by Dr. Kim Choi and Lee.
Kim Choi
and Lee. You should get it on Amazon. Amazon should have it.
Amazon.
It is there on Telegram.